professor of diabetes medicine, but I've also an interest in obesity management as well. And so I'm going to give an update on that, and these are my disclosures. So what I'd like to do is really just talk briefly about obesity, particularly in relationship to type 2 diabetes, a little bit about the current approaches to weight management, and then I'll focus on some of the new therapies, particularly the pharmacotherapies that are being developed. So this is a global problem, and it is increasing in prevalence, and this is the data from the US, where it's estimated that by 2030, approximately half of the population will have obesity and about a quarter will have morbid obesity. And on a global level, there's probably going to be 1 billion people living with obesity by 2030. It's significant because it can reduce life expectancy. So we know that if you have a BMI of between 40 and 50, which is now not so uncommon, you only have about a 50% chance of reaching the age of 70. And it is important because obesity is associated with a number of comorbidities, particularly, as you're very aware of, type 2 diabetes, but also I think increasingly we're understanding the relationship, for example, with heart failure, particularly preserved ejection fraction heart failure, osteoarthritis, gallbladder disease, and other cancers as well. Increasingly, the relationship with obesity and cancer is being realized. Now, when it comes to diabetes management, even the glucose-lowering therapies that we may choose to use may also impact on weight. So increasingly, obviously, we have some of the newer therapies, such as GLP-1s and SGLT2s, which can be associated with weight loss, and I'll come back to that. DPP-4s and metformin, we know, are probably weight neutral, metformin possibly slightly weight losing. But obviously some of the common therapies that we have used, such as insulin, thiazolidinediones, and sulfonylureas actually are associated with weight gain. Now, I've co-chaired the ADA-EASD consensus report on the management of hypoglycemia, and this is data that was published just in September and presented at the EASD in Stockholm. And this is now our overarching approach, the management of glucose lowering. But now we put the person living with diabetes very much at the center of all we do, with the ultimate goal to try and improve their quality of life and to reduce the burden of complications. And you can see that in this approach and consensus, which is focused around glucose lowering, there's now a more holistic management of type 2 diabetes, talking about glycemic management, but also weight management now has equal focus, along with cardiovascular risk management and the choice of glucose-lowering therapy to offer cardiorenal protection. Now, absolutely critical to all of this is the principles of care, good psychosocial support, self-management. Language matters. We often use very stigmatizing language in how we interact often with people living with diabetes. So all of those components, principles of care, are really important, and I don't have time to go into those. But in terms of weight management now, we recognize the importance of intensive, evidence-based, structured weight management programs in individuals with type 2 diabetes, general lifestyle advice, considering medication for weight loss, but also when choosing glucose-lowering therapies, consider in those people where weight management is important, glucose-lowering regimes which may have high to very high weight and glucose-lowering efficacy. And this is the figure in Diabetologia and Diabetes Care, which pulls all of that together. And all these slides are available on the ADA and EASD website that you can download from the article. So just to focus a little bit on the aspect around weight management, you can see here that now we have a number of glucose-lowering therapies that differ in their efficacy for weight management. We talked about the DPP-4s and metformin that are weight neutral, the GLP-1s and SGLT2s, which have intermediate weight lowering efficacy. Some of the GLP-1s, such as dulaglutide and liraglutide at the diabetes licensed dose, which are high. And we have the newer therapies now, including tirzepatide, which is now licensed in Europe and in the US, although not generally available or launched yet, and semaglutide, which have high efficacy for weight lowering in the context of being used as glucose-lowering drugs. There is more of a focus now in the guidance around obesity and weight-related comorbidities. This wasn't really a big focus before, but the recognition that in many people living with type 2 diabetes, non-alcoholic fatty liver disease, obstructive sleep apnea, and preserved ejection fraction heart failure may benefit, obviously, from weight management strategies. Now, in terms of our approaches to weight management, what we know now that progressive weight loss has a dose-dependent and tissue-dependent effect. If you can lose 5% weight loss through whatever means, that can obviously impact on a number of biological functions, for example, muscle insulin sensitivity, beta cell function. If you can lose more than 10% weight loss, then the magnitude of that impact increases, but also the spectrum of your impact widens. And when we get up to around 15% weight loss, we're starting then to have a direct effect, for example, on reducing inflammation. So any weight loss is important, but the more weight loss has a dose-dependent impact. Very broadly, we have three approaches: lifestyle interventions, pharmacological therapies, and metabolic surgery. But I think it's really important to remember that we talk about weight loss, but actually the other aspect is long-term weight management, because we know that there are a number of strategies where we can achieve weight loss in the short term, but we have much data now over time that patients tend to regain that weight. And it's, I think, important to be aware of the literature around metabolic adaptation, which tends to drive people back up. And there are a number of changes in hormones, including satiety and hunger hormones, which drive that weight regain, and also changes in energy expenditure. So we have a spectrum of interventions, lifestyle interventions, and you'll know, and I don't have time to go into the data, for example, from the DIRECT study, where there is potential with some of these intensive lifestyle interventions to get remission of type 2 diabetes in a reasonable proportion of patients with diabetes, particularly if applied early. We have various pharmacotherapies, and then we have, obviously, metabolic surgery. In terms of pharmacotherapy, the options have been a little bit limited. So we've had for a long time orlistat, you'll be aware of that, and that is available. You get around 4% weight loss, and we have to administer that 3 times a day, and it's not particularly well tolerated. In the US, there's probably more availability, and there are now, for example, liraglutide, which is a GLP-1 receptor analog, has also now been licensed for weight management, and I'll show you a little bit of data from that. So this is the SCALE trial. This is the study I was PI on, which we published in JAMA, crumbs a long time ago now, 7 years ago. If you look at the SCALE diabetes study, which is the one just here, you can see that about 50% of the population were able to get 5% weight loss. But what you will also observe, here, about 50% were able to get 5% weight loss. But what you'll also observe is that in people living with type 2 diabetes, with the same intervention, you tend to get less weight loss than you do in people without diabetes. And that's been actually observed with all of the pharmacotherapies. So you tend to get less weight loss in people living with diabetes than those without. We don't really understand why that happens. There may be the use of concomitant medications such as insulin, SUs, TZDs. The fear of hypoglycemia may increase appetite. There may be reductions in glycosuria as you improve glycemic control. There may also be primary factors, and there's some suggestion that there may be increased inflammation actually centrally, which may drive some of this. So this is an area that we know that patients with type 2 diabetes tend to get less weight loss, but we haven't completely understood the reasons for that. So where are we now with the pharmacotherapy that now exists? And now semaglutide, which is a GLP-1 receptor analog, a weekly injection of 2.4 milligrams, is now licensed and actually approved by NICE for weight management in England. And I'll just show you the data which supports this. So this is through a global phase 3 program called the STEP program. This study will be interesting because this is the cardiovascular outcome study. So what we lack in obesity management is outcome studies which show reduction in major adverse cardiovascular events. Look Ahead, which was the lifestyle intervention, was stopped after about 10 years because of futility and didn't show a benefit in cardiovascular outcomes, and there are many reasons why that may have been the case. But we will have some data coming through. But at the moment, the data is based on the phase 3 program here, and there's been recently data published in adolescents as well. So this is the pivotal study, which is the STEP 1 study. And this shows semaglutide, and it's important. So it's the 2.4 milligram dose. The dose in diabetes is 1, and a recent amend up to 2 milligrams. But this is the 2.4 compared to placebo on the background of reasonable lifestyle intervention. We can argue about that, but it was a reasonable attempt to offer ongoing lifestyle intervention. So this is the placebo arm, and you can see there was a modest weight loss. This is the semaglutide arm, and you can see that the end of treatment difference was around 15 to 17%, depending in terms of whether you looked at the effect of regardless of treatment adherence or the effects if people continued on their medication. So this is a mean double-digit weight loss, and this was really the first pharmacotherapy that has demonstrated this. And if you look at what we showed with the scale, with about 50% of people getting 5% weight loss, you're now getting nearly 90% with 5% weight loss, nearly 70% with 10% weight loss, and half of people are getting 15% weight loss. So this is a paradigm shift to a certain extent in terms of what is possible with pharmacotherapy. Now, it's not just the weight that's important, it's the impact on everything else as well. And there were impacts on blood pressure and lipid profiles, but I think this is quite important. This is on physical functioning, and there was an improvement in physical function in these patients in this study. And this shows the whole program now. So again, this observation that you don't do quite as well if you've got diabetes, but it's still almost 10% mean weight loss. And in all of the other studies, and step 4 was done on the, step 3 was done on the background of an intensive behavioural intervention where there was significant, almost a direct-like intervention in that trial. So just to finish in the last few minutes, just 5-10 minutes on where are we going, okay? And I think what we're trying to do is bridge what we know can be done with lifestyle modification on a long-term basis with adjunct pharmacotherapy, and can we try and get closer to that over 20%, which we can have with metabolic surgery, and are we able to look at also longer-term weight loss maintenance? And I think I showed this slide last year, and I think this is, from a pharmacotherapy perspective, quite an exciting field, and you're going to see a lot changing over the next few years. So if we look at these multifunctional peptides, right in the middle you've got GLP-1, and a lot of the new therapies for both weight management and for diabetes are incretin-based therapies, and as you know, we now have weekly GLP-1s. If we want to look at obesity, then we probably also need to be looking at GIP and glucagon. And if we want to look at diabetes, then there's some interest in looking at GLP-2 as well. And if we look at most of our approaches to long-term management, we usually use more than one approach. And so now we're in the phase of looking at dual or triple agonists. You can do that either by creating chimeras, where you have hybrids of two peptides bound together either directly or via linkers, or you can almost sort of design in a second pharmacological activity to an existing peptide backbone. And this is animal studies, and this is what we call the triple G. So this is GLP-1, GIP, and glucagon. And you can see after a very short time in these rodent models, the significant weight and glucose lowering that you can get. So, as I said, now we're in this field where it's almost like building Lego, where you can build these different dual and triple agonists to address some of these issues. And so one of these is CagriSema. So this is an amylin analog with semaglutide 2.4. This is the Lancet paper from May of last year, where you can see different doses of cagrilinide. I can never say, I'm just going to call it Cagri because it's very difficult to pronounce. But this is, if you look at this cohort here with the 4.5 milligrams plus semaglutide, we're getting, after 18 weeks, pretty significant weight loss. And this is just about to go into phase 3 with a program called Redefine. The trials will be in the UK and in England. We're just about to start those studies in the spring. So we'll have data coming out from this combination. And as you can see here, this is what's achieved after 20 weeks, around a mean weight loss of around 15%, and in some of the arms actually even higher weight loss. The exciting data is with an agent called tirzepatide, which is a dual agonist. So this is a GLP-1 with a GIP. So we know what we get with the GLP-1. We get reductions in body weight, increase in satiety, increases in insulin, reductions in glucagon, and an impact on hyperglycemia. GIP has some similar but also complementary effects. So it's thought to possibly have a reduction in nausea. So you may be able to tolerate, for example, the GLP-1 better. But it particularly has some impact in the white adipose tissue, where it can increase insulin sensitivity, increase lipid buffering, and reduce pro-inflammatory immune cell infiltration. And so this dual agonist may be able to improve insulin sensitivity, improve beta cell function, reduce food intake, increase energy expenditure, and improve metabolic flexibility and nutrition partitioning. And this is really important because it's ectopic fat. It's fat in the wrong place, whether it be in the liver, whether it be in the pancreas, whether it be in the heart. Actually, there's interest there that may also lead to the comorbidities that we often see associated with obesity. So this may be very important. So tirzepatide is a weekly injectable GIP, GLP-1 receptor agonist. It had a very successful phase 2 program where it lowered body weight and there were no new GI intolerability or signals. It's been tested pretty extensively in this phase 3 program called SURPASS, which has gone from monotherapy, and this is in type 2 diabetes. So this program is around glucose lowering to get a license for the management of type 2 diabetes around glucose lowering. It's not a weight management program. And there is a head-to-head with semaglutide, which is SURPASS-2, and there is an ongoing cardiovascular outcome trial, which is interesting because it's a head-to-head with dulaglutide. So dulaglutide already has shown cardiovascular safety. It's a GLP-1 selective, a GLP-1 agonist, and it's one of the few head-to-heads with an active comparator, and that's pretty much fully recruited now. So in all these studies, there are 3 doses, the 5, the 10, and the 15 milligrams, and they're compared to a placebo or an active comparator. And this is SURPASS-2. So this is semaglutide, which I've shown you the data at the 2.4 milligram dose, but this is the 1 milligram dose, and this is pretty much the best that we've got in terms of a glucose-lowering weight loss agent available currently, and you pretty much double the weight loss in this study. Remember, the main outcome is actually A1C reduction, and also in this study, the A1C reduction was about 2.5%, so pretty spectacular A1C lowering. And here, you can see that you're getting 86% to 5% weight loss, 65% to 10% weight loss, and 40% to 15% weight loss. And remember, these are people with type 2 diabetes, where I showed you that they don't tend to do quite so well in terms of weight management. The A1C reductions were pretty remarkable. So this is A1C from around 8%. And this is there's not such a big difference between the 10 and the 15 milligram dose, but you can see here in SURPASS-4, where these people were already on metformin, SGLT2 and or SUs, with an A1C of 8.5, the mean reduction was more than 2.5%. So they were going down to an A1C of around 6. They were getting pretty much across the studies significant weight loss. This is in kilograms. So in SURPASS-2, at the highest dose, around 11 kilogram weight loss. Across all of the studies, virtually everybody, or well in excess of 80%, apart from in the monotherapy study, got to 5% weight loss. And 15% weight loss in a diabetes study is pretty impressive, really. So we were pretty staggered when we saw this data. And tirzepatide has now got a license in both Europe and in the US. It won't probably get launched in the UK for some time because just of manufacturing and supply, actually. This is one sub-study from SURPASS-3 where they did MRI. So I showed you the reduction in body weight. This is the reduction in visceral adipose tissue in litres. This is the reduction in abdominal subcutaneous adipose tissue in litres. And this is the reduction in liver fat. And I'll just show you this data here. So this is one from one individual. This is a male, 59 years, who went on to tirzepatide. This is the low dose, the 5 milligram dose, on a background of metformin and an SGLT2. So his liver fat went from 27.3% to 2.6%. His BMI went from 44.8 to 36. His A1C 9.3 to 6.1. And improvements in his adiponectin and reductions in leptin. And just finally, this is the data that's just been presented in the New England Journal of Medicine. This is a weight management study. This is in people without type 2 diabetes with a weight outcome. Exactly the same doses, the 5, 10 and 15 milligrams compared to placebo. And here's the body weight here. This is the mean weight loss, 21.4% and 22.6%. Again, not massive differences between the 10 and 15 milligram doses, but really impressive, and therefore will support, the SURMOUNT program will support a license for weight management. And here you can see that the percentage of people getting to body weight targets, more than nearly 60% are getting 20% weight loss, and really shifting people across that in terms of weight loss. And just finally, that the way of weight loss, of course you lose some lean mass, but the ratio of weight loss is slightly in favour of tirzepatide in terms of preserving lean mass compared to placebo. So I think that's something we're going to need to keep an eye on, but it looks pretty reassuring, and no new safety concerns. So I think I'll leave it there. It's obviously a rapidly moving field with some really exciting therapies coming through. Thanks very much for your attention.